My name is Max Feinstein and I'm a pediatric anesthesiologist at the Mount Sinai Hospital in New York City. And in this video, I show you a dramatic and relatively common emergency in pediatric anesthesiology. Let's dive into it. All right, Jimmy, just like we talked about, we're gonna get ready to go to outer space. And in outer space, there's no oxygen, so we're gonna have to go ahead and use that mask that you saw in the pre-op area, start breathing in some oxygen, and fill up those lungs as we get ready for a trip to outer space. And imagine what it's like walking onto the rocket ship right now, taking nice deep breaths of oxygen as we're on the launch pad, just thinking about what it's gonna be like once we get up to outer space. And astronauts say pretty commonly that as you get ready for blast off, it can start to get a little smelly because of the fuel that's used on the rocket ship, but that's okay. We're gonna get ready to take off right now. Sometimes people get a little sleepy. You're doing a great job. Boom, dude, that's it. All right, Jimmy, just like we talked about, we're gonna get ready to go to outer space. Depending on the patient and the circumstances, I like to employ imaginary themes like going to space or going scuba diving and seeing fish in order to help patients feel more comfortable having a mask on their face. The reason why they have to have a mask on their face is twofold. Number one is to fill up their lungs with oxygen. This is called pre-oxygenation and is a really important process for increasing our margin of safety after the patient goes under anesthesia. Basically, it gives us a longer period of time if the patient stops breathing for any reason so that they don't desaturate, their oxygen levels won't go down. The second reason why, in this case, we have a mask on the patient's face is to be able to actually deliver the anesthesia. So this is called an inhaled induction, meaning that the patient is going to breathe in the medication that has them go to sleep. This is different from an IV induction, where we have an IV in place and then administer the anesthesia through the IV and have them go to sleep that way. I actually made a separate video about inhaled induction versus IV induction and put a link to it right here if you'd like to check it out. And in outer space, there's no oxygen. So we're gonna have to go ahead and use that mask that you saw in the pre-op area, start breathing in some oxygen and fill up those lungs. So as I'm going through this process, I'm talking with the patient, but I'm also taking a look at their vital signs. From top to bottom here, you can see their EKG rhythm strip, their heart rate is 96, their oxygen saturation is 99, and I'm also looking at the anesthesia machine at the size of the breaths that the patient is taking. And I had them start breathing just now, so we don't have a very good tidal volume, that's 24 cc's. So I'm going to encourage the patient to take large breaths to really fill up those lungs with oxygen. As we get ready for a trip to outer space. And I'm also taking a look to make sure I've got all of my airway equipment, my IV equipment, and emergency medications, as well as the regular medications that I intend to use. And imagine what it's like walking onto the rocket ship right now, taking nice deep breaths of oxygen as we're on the launch pad, just thinking about what it's gonna be like once we get up to outer space. You can see that the tidal volumes have come up to 175, so that's a pretty good amount for a patient who's 5 or 6 years old and weighs 20 kilograms. And astronauts say pretty commonly that as you get ready for blast off, it can start to get a little smelly because... So I mentioned getting a little smelly because I'm just turning on the anesthetic agent here, which you can see with my right hand, I'm turning the dial for the sevoflurane. It's not a terrible smelling medication, but it is described as being a little pungent. So if you don't warn a patient that they're about to smell something that's a little funky, then it can be disconcerting. So I like to include this as part of my rocket ship theme and just say that it's the rocket fuel, and that's all that they're smelling. The fuel that's used on the rocket ship, but that's okay. We're gonna get ready to take off right now. Sometimes people get a little sleepy. So you can see that the patient's eyes just closed. The process of doing an inhaled induction can take anywhere from 30 to 60 seconds, and it's really important to make sure that the patient is completely under general anesthesia before attempting to do anything like placing an IV or manipulating their airway. The reason for that is as a patient goes under general anesthesia, especially with an inhaled induction like this, they become what's called hyperexcitable, in the sense that if there's anything painful that happens to them or stimulating in any kind of way, there's a pretty high risk of their vocal cords snapping shut. And remember, this is before we have an IV in place or an endotracheal tube, so that can really be problematic. That's why it's important to make sure that the patient has gone completely to sleep before attempting to place an IV. You're doing a great job. During this process, I'm constantly panning between the monitors and the patient to make sure that all the vital signs look okay and to make sure that the patient's chest is actually rising and that they're clearly exchanging oxygen. Seeing the patient's heart rate increase is a normal part of undergoing an inhalational induction. So this is the beginning of that hyperexcitable phase. You can see that the heart rate's gone from where we started at 96 to now 104. So I expect to see this. Now you can hear that noise in the background. It's a little subtle, but this is actually what's called inspiratory stridor. And what that means is that there is something that's blocking the free passage of air between the mask and the patient's lungs. This is concerning for me because that potentially compromises my ability to continue delivering oxygen and anesthesia to this patient. Along with this, you can see on the screen that the patient's tidal volume has now gone down to 46. So clearly there's something that's getting in the way, and it's most likely the vocal cord in this circumstance. For that reason, if I back up for just a second, you can see that I did a maneuver called a chin lift, and what that means is I'm basically picking the patient's chin up a little bit in a way that can hopefully relieve any type of airway obstruction. A chin lift is one of the first line maneuvers to do in cases of suspected laryngospasm. That move that I just did there is called closing the APL valve, which basically increases the amount of pressure that I'm delivering through the anesthesia circuit. So this is delivering continuous positive airway pressure, which is another maneuver that's designed to break laryngospasm, which is what I'm starting to suspect might be happening based off that inspiratory stridor and then also the fact that the flows have gone down. So now I'm really starting to get concerned because in addition to the findings that I just described, the patient's oxygen saturation is also going down, which is clearly problematic. You'll also notice that that inspiratory stridor sound has disappeared, which at first blush might seem great because that would suggest that the problem has resolved. But in reality, a complete disappearance of inspiratory stridor after you heard it might mean that the vocal cords have now completely closed to the point that no air is moving whatsoever and no oxygen is getting to that patient's lungs. You can see on our flow meter here that our tidal volumes are severely down, and I'm on my capnogram, which is the amount of in-tidal CO2, which is what the patient is breathing off, has gone to basically zero. This has made me extremely concerned at this point that there is no air that's being exchanged with the patient, and this is an emergency that is most likely laryngospasm. That background noise that you hear of the pulse oximeter tone dropping is a terrifying sound to hear and means that clearly there's a problem that needs to be fixed right away. Because when the oxygen saturation drops, then eventually the patient's heart rate will drop and this can lead to a cardiac arrest. So the medication that I've grabbed here is called succinylcholine. And what you can appreciate is that even though we have no IV access for the patient, this tiny needle is an intramuscular needle. So that allows me to deliver succinylcholine, which is a paralytic, even though we don't have IV access. So this is actually one of the key emergency medications in pediatric anesthesia. And I made another video about all of the other emergency medications in pediatric anesthesia, which you can view here. I'll also just point out that as an attending pediatric anesthesiologist, it's extremely important to me that whenever I'm working with a trainee, a resident, or a fellow, that they know exactly how much succinylcholine needs to be delivered to the patient, which depends on how much that patient weighs. So I always ask my trainees before we get started with the case if they have the medication available on an intramuscular needle and they know exactly what the weight-based dosing is for the patient who we're going to take care of, because as you can see in this type of situation, there's really no time to stop and think about what the dose is. do the math and then administer the medication. So that all has to be ready to go before we get into the operating room with the patient. The other medication that I'm reaching for here, which is also being delivered on an intramuscular needle, is called atropine. Atropine is a medication that, among other properties, will increase a patient's heart rate. The reason why I'm administering it in this situation is because succinylcholine can actually decrease a patient's heart rate. And as you can tell, this patient's heart rate is already going down because they don't have enough oxygen. So in many circumstances, if I'm giving succinylcholine, I'll also give atropine to make sure that the heart rate goes up. This is a terrifying number to see on the screen. You can see how quickly we went from an oxygen saturation of 99% now down to 27%, which means that we are very close to the patient having a cardiac arrest because not enough oxygen is getting to the heart itself. What I'm doing here is now trying to deliver oxygen to the patient, again through the mask, after having administered succinylcholine, the paralytic. Succinylcholine acts very quickly to cause the vocal cords to relax, which then allows me to pass oxygen between the vocal cords. So that's what I'm doing right now to try and get the oxygen saturation back up to a safe place. And you can already see my first indicator of success here, which is a tidal volume of 145. That makes me pretty confident that in a short period of time, oxygen is getting to the patient's lungs and then will be circulated throughout their body. I'm also looking at the patient's end-tidal CO2 here. Again, that's what the patient is breathing off, and that's another reassuring sign that I'm able to exchange air in the patient's lungs. You can see that the blood pressure cuff had just cycled and the patient's blood pressure dropped significantly, which is not surprising because anesthetic agents tend to drop blood pressure, but also the heart rate had slowed down considerably. And for pediatric patients, their blood pressure depends in large part on their heart rate, much more so than adults. So I'm not surprised to see that the patient has become extremely hypotensive. And obviously this is very reassuring to see the oxygen saturation coming up very quickly, so I'm happy about that. So at this point, the patient is paralyzed for maybe 5 to 8 minutes based on the succinylcholine that I gave, but they're also under anesthesia because remember, we had already induced general anesthesia. So I'm not concerned about them being aware of anything that's going on at this point. Again, I'm constantly scanning the monitors to make sure that the vital signs are appropriate, and here I'm pretty happy with it. You can see that the heart rate is pretty fast, but that's not surprising because I had administered atropine to increase the patient's heart rate. And my next move here is going to be securing an airway because I want to make sure that there's no issue with laryngospasm before the paralytic wears off. And then after that, the next big priority is getting IV access so I can administer medications in the most effective way possible. I'll just highlight again the importance of making sure that you have everything that you need within arm's reach right here. I've got all of my Airway equipment. These were my medications that I just used, and then this is IV equipment here that I'll use to place an IV after I establish an Airway. Under ordinary circumstances, the order of operations for pediatric patients would be induce anesthesia by having them inhale the medication, and then place an IV. And once an IV is placed, then I would go ahead and intubate the patient. But again, based on this specific circumstance, it's important to just go ahead and establish airway access, and then I'll be able to establish IV access afterwards. I'm hanging on tightly to the endotracheal tube because I haven't taped it right now. It's very helpful to have an assistant in an emergency circumstance. So in reality, as soon as there was a laryngospasm that I suspected, I would have asked for backup, having another anesthesiologist come in. But in this case, it's just me, so I'm hanging on tightly to that endotracheal tube so it doesn't come out. Here I'm just placing a little bit of air into the endotracheal tube cuff to keep it secure inside of the trachea. I just turned on the ventilator, and now I'm going to establish IV access as fast as I can, so if I need to administer more medications, I can do that in the most effective way possible. If you found this video interesting, you might want to check out this video that I made where I go through all of the emergency medications that are used in pediatric anesthesia and describe exactly why each one of them is used. Thank you very much for watching. I'll see you next time.